Hello, I'm your host, Neal Howard, here on Health Professional Radio. Glad that you could join us. Our guest is Dr. Robert Hiros with Spinal Diagnostics, and he's been with them since about 2014 or so, and he's joined us today to talk about complex regional pain syndrome, or CRPS, and a method by which he was able to restore one of his patients back to a very high level of mobility after suffering from CRPS. Welcome to Health Professional Radio, Dr. Robert Hiros.
Thank you. Great to be here.
Glad that you could join us today. Give us a bit of background about yourself. You are at Spinal Diagnostics, been there for about 3-4 years. What was your specialty going into medicine? Is this something that you've always been interested in?
Well, my field of medicine is physical medicine and rehabilitation, which does a lot of different things, but I subspecialized into pain management several years ago, and more into spine pain. So at Spinal Diagnostics, we focus on diagnosing and treating all types of spine pain and chronic nerve pain.
So injuries or neurological issues that happen because of illness, not necessarily injury, sports injuries, it runs the entire gamut?
Absolutely. Really, no matter the cause of spine pathology or pain, whether it's aging or degenerative changes or trauma or disease, we just focus on trying to come to an accurate diagnosis and then forming a good treatment plan for each patient individually.
Now, when talking about this pain, and it's not just any type of pain, it's a specific type or class of pain, complex regional pain syndrome. Explain to our listeners exactly what that type of pain is.
Sure. Complex regional pain syndrome, or CRPS, as you mentioned, is a very unique and very difficult to treat syndrome. It is typically found after a specific injury to either an arm or a leg. And oftentimes it's just a pretty innocuous injury that somehow spirals out of control and leads to a very severe, disabling neuropathic pain condition.
And this is a chronic pain condition unless treated.
Absolutely. It's very difficult to treat CRPS effectively. And for years, if not decades, we've kind of tried everything from medications, physical therapy, injections, acupuncture, massage, even spinal cord stimulation, and nothing really helps it enough.
Now, earlier this year, you encountered a gentleman by the name of Jason Bowling who was suffering with just this type of pain, this CRPS. He had tried everything. He had been everywhere. And he was just about to do a last-ditch effort, for lack of a better term, to relieve some of this severe, chronic, untreatable pain with amputation. Talk about your encounter with Mr. Jason Bowling back around about February of this year.
Well, Mr. Bowling came to me from his podiatrist, who had been at a talk that I gave on CRPS. And he was, as you said, he was literally 3 days away from electively amputating his left leg below the knee because his pain was so severe and had failed to respond to everything, including all of the things that I had just mentioned, I believe. He had severe nerve pain in the foot. He had had multiple foot surgeries. He was unable to ambulate without crutches. He couldn't work. He was taking high doses of opiates. He just had no quality of life. He was pretty miserable.
And you were able to forego that amputation based on DRG, or this Dorsal Root Ganglion Therapy. How new is this therapy? Is this something that's not relatively new, but just little known?
This is fairly new in the United States. Okay. It was FDA approved about a year ago, last spring. In my state of Oregon, the very first cases were performed, I believe, in July of 2016. It has been done in Europe and Australia for several years, so it's kind of been out there on the horizon. We knew it was eventually going to be FDA approved here, but it's pretty brand new.
Explain how it works. You mentioned spinal cord stimulation earlier in the conversation, and I'm imagining something along those lines, but explain to me how it differs from traditional SCS.
Sure. The primary differences between DRG stimulation and traditional spinal cord stimulation is the location of the electrodes and the specific spinal structure being targeted. So the DRG stimulation utilizes the Axiom neuromodulation system, which is made by Abbott, and it provides electrical stimulation directly to the dorsal root ganglion, which is a small nervous structure that is located in the neural foramen on the left and the right at every spinal level, from the cervical spine down to the lumbosacral spine. And traditionally with normal spinal cord stimulation, you're placing electrodes in the epidural space, in the midline, dorsal to the cord itself, usually up in the thoracic spine. And the DRG stimulation focuses on typically 1, 2, maybe 3 levels, targeting specific nerves.
Now, I understand that this DRG therapy eliminated the pain for Jason. What are the chances of this therapy eliminating or reducing sensation where no pain exists?
Well, I think it really comes down to matching the right therapy to the right patient. And then that's important in all forms of spinal intervention. But I think with DRG stimulation, it's critical. For the right patient, when matched with the right patient, DRG therapy has honestly had success that I didn't expect and that I haven't seen in any other pain management intervention in my entire career. It is certainly not a guarantee, but I think for the right indication, it's probably very likely to be of benefit. How much benefit is going to be an individual variance patient to patient. We typically consider any type of spinal stimulation successful if it gives the patient 50% subjective pain relief. But with DRG, it has not been uncommon at all for people to see 80%, 90% relief, or even more. It's really been remarkable.
So what are I guess some of the basic criteria to determine whether or not a patient is, as you say, the right patient or candidate for DRG?
Well, it's the type of pain and the location. The type of pain, it is specifically FDA approved for peripheral causalgia and complex regional pain syndrome. But really we're talking about a very focal, localized neuropathic pain, typically of the groin, the knee, or the foot and ankle, which are all areas and types of pain that are fairly difficult for traditional spinal cord stimulation to effectively treat. So if I see a patient who has severe neuropathic pain of the lower extremity, and it's very localized to one of those regions, and they have tried and failed conservative therapy, then fairly quickly I'm going to be thinking DRG stimulation may be a viable option for them.
How much damage does an extremity or an area have to sustain before this type of therapy can be ruled out?
I don't think there's necessarily a threshold of a level of injury because, one of my patients who has just had phenomenal success with DRG stimulation developed CRPS of her knee after simply doing a squat exercise on roller skates. And she just did a squat, and that's it. Felt pain in her knee develop, and that led her on a path and ultimately developed CRPS. So certainly sometimes it is post-operative when we know there's been a specific nerve injury or post-traumatic, but sometimes it's just a very mild thing. So the decision is not made on, why it happened or how it happened. It's really just, is this neuropathic pain first and foremost? Is it very localized? Is it CRPS? Have they tried and failed more conservative options? And is it, this isn't for very mild pain. So I probably wouldn't offer this to a patient with mild or moderate pain that wasn't really affecting their quality of life. This is more for the more advanced cases that really have trouble functioning on a day-to-day basis because of their pain.
How effective is the therapy in, say, younger candidates, if those have been identified in this short period of time that this therapy has been FDA approved, maybe in the teenager or young adults?
Yeah, I think there isn't hard data accepted yet, but the early experience seems to indicate that the earlier you do this in the course of CRPS, the better chances you have of treating it effectively. So if a patient has had CRPS for 6 months and they've already tried conservative therapy, then I would do this as soon as possible. And I think it's more likely to be of benefit than somebody who's had CRPS for 10 or 15 years, for example. Now, that said, I've seen it work very well in both, long-term chronic pain and more short-term chronic pain and of varying ages.
When dealing with long-term chronic pain using DRG, what types of maintenance is required? I mean, this is a permanent implant, in much the same way as a pacemaker. Is this something that can be left alone by the patient and or the caregiver, or is there routine maintenance that's involved with the apparatus and the procedure itself?
Once the patient has recovered from the permanent implant, and I usually say permanent with quotes around it because these systems can be removed for whatever reason if necessary, so it's not as if they're stuck with it forever. But once they've recovered from that minor surgery and the stimulator, the unit has been programmed by the Abbott representative, it is kind of just a set it and forget it type of treatment. So patients have a wireless remote controller that they have with them. And I think when they're out and around on a day-to-day basis, they don't even think about it or carry it with them. They might take the controller with them if they go out of the country on a long vacation or something like that. But for the most part, once it's dialed in, it's kind of just there and it runs 24/7 in the background and they forget about it. That's one of the nice things about it.
Now, I understand that you did a tour at the Pink Elephant, I do believe.
Yeah, yes, I did. Absolutely. I haven't heard that term in a while.
I'm dating myself. Dating myself for sure. What do you see as far as any of the military applications? Do you see this as being a seamless transition for them as well as the civilian world?
Absolutely. Having served in the Army Medical Corps, those patients are near and dear to my heart. And I think there's a lot of complex regional pain syndrome in the military population that would benefit from this. As a civilian physician, my only frustration is that sometimes the military system is, as we all have heard in the news, it's difficult for these patients to get out into the civilian community for treatment. But I know they're there, and I'm working hard to find them.
From one veteran to another, thank you so much for your service.
And back at you.
Where can our listeners go and get some more information about Spinal Diagnostics and the Abbott Dorsal Root Ganglion Therapy?
Obviously, the Abbott website is going to have a lot of information, and I believe that they have a website called poweroveryourpain.com. Our website at Spinal Diagnostics is spinaldx.com. There's a whole separate page about DRG stimulation there, and I'm excited to say that hopefully within a week or so, I'm going to have a real nice video focusing on Jason Bowling and his story up on the website as well. He's been a real inspiration for a lot of people.
Absolutely. It was a great pleasure speaking with him, as it has been with you as well. Thank you so much for joining us today.
My pleasure. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. Robert Heroes, talking about complex regional pain syndrome and dorsal root ganglion therapy. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes, listen in, and download at SoundCloud.